How do we diagnose this? We will usually take a sample from the cornea, called a scrape or swab from the surface of the eye, to send to a specialist laboratory. This can help and confirm the diagnosis. It is usually painless, but is very helpful in determining which microorganism can cause the infection and help guide the treatment that we use. Unfortunately, the tests do not give us an answer immediately and may not prove positive even if the picture is convincing for microbial keratitis. Drugs are often therefore started with knowledge of what the common infections are going to be. It is helpful you keep your contact lens solution and contact lenses if you use them and bring them with you to your visit. These can then be sent on to the laboratory and may help guide treatment. Suffice it to say, the contact lenses will not be returned. So how do we treat this? The treatment of microbial keratitis depends on its severity. Infections of the eye surface are treated with intensive antiseptic drops or eye ointment. You will need to use these up to every half an hour during the day and night as directed by your doctor. This is because conventional tablets or injections of antibiotics will usually not reach the cornea infection sufficiently, although you may be prescribed tablets as well. The first few hours and days are crucial to prevent the infection from getting worse. If you are unable to instill drops or ointment yourself or with the help of a friend or family member, you may need to be admitted to hospital for treatment. You will be monitored closely, a review organised within a few days. Usually the antibiotics will be tapered if you respond to treatment, but it is sometimes necessary to increase or change them depending on information from the laboratory or your response. If the deeper layer of the cornea is affected, called the stroma, then antiseptic treatment may not be enough. Steroid eye drops may be needed to reduce inflammation. Steroid eye drops, however, must be used under the supervision of an eye doctor, because although they improve inflammation, they can potentially make the infection worse. Complications of the ulceration themselves can be slow to heal and in rare circumstances causes severe inflammation of the cornea, called melting. This is a serious complication and is more common with certain types of infection. It may require surgery to try and seal the ulceration, for example with the help of a special glue. Longer term, scarring and blood vessel growth may limit vision sufficiently for surgery to be considered to replace the front layer of the cornea and occasionally all layers of the cornea, called a corneal transplant. Treatment itself may also cause problems. Some antiseptics can cause the surface of the eye to become sore, and with prolonged treatment, they may in fact prevent healing. Steroid drops, as we mentioned, can make the eye more vulnerable to infection being treated or to other infections. They can also cause the pressure in the eye to rise, which can lead to damage to the optic nerve at the back of the eye, called glaucoma. It can also cause clouding of the lens, a process called cataract. We will usually monitor the condition closely as an outpatient. It is essential to attend the outpatient clinic to monitor this. Subtle changes may not be obvious to see or feel and can only be detected by slit lamp examination or by specialist scans of the surface of the eye, such as corneal topography and OCT. Regular follow-up appointments are offered so the deterioration does not go unnoticed and can be treated early on. It may also be necessary to organise additional visits to an optician to help optimise your vision, and this may include the use of specialist contact lenses as infection resolves.